Hello everyone, today's topic is midbrain. Anatomy of internal features of midbrain at the level of superior colliculi. Cut section of midbrain presenting central gray matter along with cerebral aqueduct. Substantia nigra. This feature remain common at both the levels. Crus cerebri remain same at both the levels, at the level of superior collicular and at the level of inferior colliculus. Transverse section of midbrain at the level of superior colliculus. This section is at the level of superior colliculus. These are superior colliculus. Nuclei closely related with central gray matter. Number 1 nuclei is oculomotor nerve nuclear complex. There will be presence of oculomotor nerve nuclear complex. There are various subdivisions of this complex. Each individual right and left side divided into subdivisions. This is oculomotor nerve nucleus complex. Subdivisions of oculomotor complex are inferolateral nuclei will supply fibers to inferior rectus muscle. Ventromedial nuclei supply fiber to medial rectus muscle. Intermediate nucleus supply fibers to inferior oblique muscle, and caudal central nucleus it will supply fibers to levator palpebrae superioris muscle. Number 5th subdivision is median raphe nucleus will supply the fibers to superior rectus muscle. So here only two extraocular muscles are left beyond oculomotor nucleus. Those are lateral rectus supplied by abducent nerve and superior oblique supplied by trochlear nerve. So this oculomotor nerve complex will supply the somatic efferent functional components. Therefore, they will supply these extraocular muscles which are derived from somoid. So this is oculomotor nerve nuclear complex lies in anterior part of central gray matter. This complex subdivided into 5 nuclei: inferolateral nuclei, ventromedial nucleus, intermediate nucleus, caudal central nucleus and median raphe nucleus. These are subdivisions of oculomotor nerve complex. Next nucleus which will present in central gray matter exactly cranial to oculomotor nerve nucleus is Edinger-Westphal nucleus. This is Edinger-Westphal nucleus. It is a parasympathetic component of oculomotor nerve nuclear complex, but it will carry general visceral efferent functional component. This Edinger-Westphal nucleus it will supply parasympathetic secretomotor fibers through ciliary ganglion which will help in constriction of pupil. It will supply sphincter pupillae muscle. It will supply one more muscle called ciliaris. This ciliaris will do accommodation for the near vision. Next nucleus is mesencephalic nucleus. Next nucleus, main component of this section is red nucleus. Red nucleus present dorsal to medial part of substantia nigra. In freshly cut sections, it will appear pink in color because of abundance of iron pigment. It will be extending from the level of superior colliculi till almost the subthalamic nucleus level. This is a main component of identification of midbrain at the level of superior colliculus. This is red nucleus. This red nucleus will have ventral tegmental decussation, called as ventral tegmental decussation of Forel, which form rubrospinal tract. So this red nucleus will have ventral tegmental decussation of Forel, which gives rubrospinal tract. So this red nucleus, main component of this section at the level of superior colliculus. This is the main component of identification of midbrain at this level. Connections of red nucleus. Some afferent connections and some efferent. Afferent connections are cerebello-rubral fibers from contralateral half of cerebellum, from dentate, emboliform and globus nucleus. Cerebello-rubral fibers. From emboliform globus connected to magnocellular part of red nucleus. This one is older portion. Magnocellular portion is older portion. So emboliform and globus connected to magnocellular portion and dentate fibers connected to parvocellular portion of red nucleus. What is parvocellular? Newer portion of red nucleus. Next afferent connection is from cerebral hemisphere. Same side cerebral hemisphere. Then efferent connections, outgoing channel. Number 1, rubrospinal. Number 2, rubrobulbar. Rubrobulbar will supply efferent fibers from red nucleus to motor nucleus of trigeminal nerve and facial nerve. Rubro-reticular tract from red nucleus to reticular formation of entire midbrain. Rubro-olivary tract from red nucleus to inferior olivary nucleus. Next structure which will present at the level of superior colliculus is dorsal tegmental decussation of Maynard, also called as tectospinal tract. Dorsal tegmental decussation of Maynard, tectospinal tract. Efferent fibers coming from superior colliculi give crossing and form this decussation. This is dorsal tegmental decussation of Maynard formed by efferent fibers coming from superior colliculi. Next structure which will be present at the level of superior colliculus are medial lemniscus, trigeminal lemniscus and spinal lemniscus. So lemnisci only 3 in number. Most medially is medial lemniscus, next to it trigeminal lemniscus, and next to it spinal lemniscus. These lemnisci are common with that of cross section at the level of inferior colliculus. But lateral lemniscus, which is auditory pathway, it will submerge with inferior colliculus, so there is no lateral lemniscus at this level. Next thing is pretectal nucleus. This is pretectal nucleus present anterolateral to superior colliculi. It will directly supply fibers to Edinger-Westphal nucleus concerned with pupillary light reflex. So this is pretectal nucleus present anterolateral to superior colliculi, and it will directly supply fibers to Edinger-Westphal nucleus concerned with pupillary light reflex. Next structure is superior colliculi, ovoid mass present at the tectum. Connections of superior colliculi are afferent and efferent. Afferent fibers coming from retina called as retinotectal fibers. These are retinotectal fibers towards superior colliculus. Next is corticotectal fibers from visual area number 17, 18 and 19. Next is spinotectal fibers will carry sensation in form of cutaneous receptors, cutaneous sensations from spinal cord to superior colliculi. Next is ipsilateral inferior colliculus. This is superior colliculus, and some fibers from ipsilateral inferior colliculi. Auditory impulses are coordinated with visual impulses via this connection. Efferent connections are tectospinal and tectobulbar. This is tectobulbar, also called as tectonuclear. This tectobulbar, this superior colliculi will send the fibers to cranial nerve nuclei number 3, 4 and 6, which is required for the movement of head and neck, movement of eye towards the source of sound. So these two tracts, tectospinal and tectobulbar, are involved in movement of eye and head and neck towards auditory stimuli, and movement of eyes and head and neck towards cutaneous stimulation. Tight closure of eyelids when exposed to bright light. And number 4 action is scanning movement of object. Whenever your eyes are scanning the objects which are moving to and fro, this movement controlled by tectospinal as well as tectobulbar tract, and moving the head and neck towards the source of auditory stimuli. So this is transverse section of midbrain at the level of superior colliculus. This is red nucleus. This is rubrospinal, medial lemniscus, trigeminal spinal, lateral lemniscus is absent. This is oculomotor nerve nuclear complex. This is mesencephalic nucleus. This is pretectal nucleus. This is Edinger-Westphal nucleus. Clinical anatomy at the level of midbrain. Some syndromes. Number 1 syndrome is Weber syndrome. In Weber syndrome, there may be occlusion of oculomotor nerve and involvement of pyramidal tract. So this blue area showing involvement of oculomotor nerve and pyramidal tract. And because of this, occlusion Weber syndrome appears. Because of occlusion of oculomotor nerve, there will be symptoms. Symptoms are, because of this, there will be unilateral paralysis of levator palpebrae superioris. There will be unilateral ptosis, drooping of eyelid, loss of sphincter pupillae and ciliaris muscle. Pupil will remain dilated and fixed. And lateral squint or lateral statismus due to normal lateral rectus muscle, and other remaining extraocular muscles will be paralyzed. Because of involvement of pyramidal tract, there will be upper motor neuron type of paralysis in opposite side of body. So this is all about Weber syndrome. Next syndrome is Benedict syndrome. Benedict syndrome, because of involvement of lesion of red nucleus, medial involvement of medial lemniscus, involvement of oculomotor nerve and involvement of superior cerebellar peduncle. So this blue area showing area of occlusion of red nucleus, medial lemniscus, oculomotor nerve and sometimes superior cerebellar peduncle and causing Benedict syndrome, creating Benedict syndrome. Because of lesion of red nucleus, functions of red nucleus also will lost, and medial lemniscus involvement causing conscious muscle joint sensation along with touch pressure. These sensation will be lost in contralateral half. Due to oculomotor nerve lesion, symptoms of Weber syndrome appears. So this is all about Benedict syndrome. Next is Perinaud syndrome. In Perinaud syndrome, this blue area showing involvement of Perinaud syndrome. Compression of tectum region by pineal gland in the area of superior colliculi. It will produce Perinaud syndrome, also called as upward gaze syndrome. So this is Perinaud syndrome, this is Benedict, and this is Weber syndrome. Area of involvement. This is Perinaud syndrome, upward gaze syndrome. A quick revision. In cut section of midbrain at the level of superior colliculus in the central gameter, crus cerebri and substantia nigra will be remain same. Presence of oculomotor nerve nucleus complex, Edinger Westphal nucleus, mesencephalic nucleus, red nucleus, rubrospinal tract, ventral tegmental decussation of Forel, connections of red nucleus, lemnisci, medial, trigeminal and spinal, pretectal nucleus. So this is transverse section of midbrain at the level of superior colliculus. And these are involvement of Weber syndrome, occlusion of oculomotor nerve, involvement of pyramidal tract. Perinaud syndrome, involvement of red nucleus, oculomotor nerve, medial lemniscus. And this is Benedict syndrome, and this is Perinaud syndrome, compression at the level of superior colliculus in area of tectum. So this is all about cut section of midbrain at the level of superior colliculus and some applied aspect. Thank you very much.